think we'll go ahead and get started. We're at the top of the hour now. Welcome everyone to this webinar on giving talks on single payer with Dr. Anna Malinow. Anna, make sure you're here and ready to go.
Yes, I am. Can you hear me?
Great, we can hear you.
Yes.
Okay, good. Excellent.
Great. Dr. Malinow is a past president of Physicians for a National Health Program and a pediatrician at Children's Hospital of Pittsburgh. And Anna, I'll turn it over to you.
Okay, excellent. Thanks, Matt, for the introduction, as well as to Emily Henkels for the opportunity to give this talk this evening, and thank you to everybody who is calling in this evening. So can everybody, I hope, see my presentation? Oh, this is interesting. Matt, we have a problem. Oh, there we go. All right, good. I have no conflict of interest to disclose, and I just wanted to tell you a little story about when I first started with PNHP about 17 years ago, I believe. I heard a talk by Deb Richter. She was not really teaching us much about the healthcare system, although of course I learned some facts about single payer, but what I learned from Deb was how to talk about single payer. Focus was on talking to business people. In fact, she claimed, and I believe her, that she talked to every single Chamber of Commerce in Vermont about single payer. Now, I can't claim to be half as good as Deb, but my goal this evening is for you to learn how to talk about single payer effectively, and the emphasis is on effectively. Now, in my experience, there's presentations. The presentation we give our peers will have evidence, statistics, graphs, and references that make the case for single payer. The presentation we give to non-medical audiences with healthcare stories, narratives, personal give and take that allows the audience to reflect and recognize the merits of Medicare for all. And then this presentation. Now, I read what you all wrote about what you'd like to gain from this webinar, and it seems that what you want to learn is learn more about single payer, how to fund it, and talking points for your peers and for the public. So I hope that this presentation that you are about to hear tonight will meet your needs. It'll have a little bit of this, a little bit of that, from soup to nuts. So when we talk, what should our objective be? It could be to educate people about single payer. It could be to mobilize the audience. But really what we secretly want at the end of every one of our presentations is for people to stand up and shout, "Everybody in, nobody out." Isn't that right? We want to make converts of them and for them to make converts of others. Now, my guess is that you are already converts, so my objective tonight will be different. If I do my job right, by the end of the hour, you will have the basic structure of any presentation on single payer. You will learn one way to get audience buy-in. You will identify universal guiding principles with your audience. You will see how these principles seamlessly allow your audience to recognize how single payer meets all those principles. And finally, you'll give your audience what they want, a set of effective tasks that they can take with them when they leave. So hopefully by the end of this hour, you will have all the building blocks necessary to develop your own effective presentation about single payer best fitted to your audience. Now, it's important to know your audience. Everybody says that. Most simply, your audience is whoever comes to your presentation. And these are some of the presentations that I have given over the years. However, and I have found that no matter who your audience is, the basic template of my talk is always the same. So let's get started. Just to let you know, your vision isn't going bad. You're not having a retinal detachment. I will explain to you why some slides are blue, okay? You will start with a personal story, get your audience to buy in, teach them the building blocks of our healthcare system, talk about costs and outcomes, come up with a set of non-negotiable universal guiding principles, show them how HR 676 meets all those principles, anticipate their questions by talking about how we pay for single payer, show them how most Americans support Medicare for all, and finally, empower your audience to complete one task, which will build your army of converts. Now, finally, don't forget about evaluating your talk and following up with the organizer of the event. And you can see that I've put a number 1 or 2 after each one of the bullet points. That gives you 11 slides that make up the skeleton. That's it. Everything else that you add is detail. Now, before you show up, if you're doing this obviously at a grand rounds, then you don't need to have somebody introduce you, and you don't have to worry about the computer and so forth. But otherwise, you really should send your bio to the organizer so you can be introduced. Matt did have some kind of handouts ready and sign-up sheet and identify someone in the audience, usually the organizer, to help you with them. Don't forget about logistics such as computers. As we're hearing now in Maui, the computer is not working. Make sure that that's straightened out before you arrive. Your flash drive, your projector, or you can use large Post-its and markers. And make sure that you bring some business cards, because I guarantee you in the community, someone in the audience will ask you to come and talk to his or her group. Now, the blue background on this slide is not a mistake. It is here to remind me and you that from here on out, the slides with the blue background are the template. And these 11 slides that you will see make up the basic structure of any presentation. So, I'd like to dedicate this talk to Devontae Johnson, who died when he was 13 of a highly treatable tumor because he was uninsured. It's also dedicated to the 728 Pennsylvanians who will die this year because they are uninsured, and to the 26,000 Americans who will die unnecessarily this year because they are uninsured. Now, this is my story. You will come up with your own. You will put in the statistics from your own state, and I will show you how to do that. Now, I never thought stories were important until I saw how effective they were. And I'd like to tell you a personal story about a personal story. As a pediatrician, we're learning how to talk to parents who refuse to vaccinate children. And I have to be honest with you, it is one of the most difficult conversations that I have probably on an every other weekly basis. It turns out that storytelling can be used with some success when we are confronted with parents who refuse to vaccinate their children. So if stories work to convince parents to vaccinate their kids, our stories of patients dying or suffering because they are victims of our current healthcare system might convince some in our audience that our system needs to change. Now, just because we start with a story doesn't mean we don't use references. And you can see that every single one of my slides pretty much will have references. And of course, if you're used to giving grand rounds presentations, I don't need to tell you that you need to include references. But there's even a reference here to the anti-vaccine article. I usually mention this at the beginning of all of my presentations, not the story, but I mean the references, to let them know I'm not making any of this up. So I'd like for us to go through a little exercise. I know that you're all at home or in your office by yourself, but I just want you to raise your hand if you've ever been uninsured, and keep your hand up. And if you could see me, you would see that I have raised my hand because I was uninsured at one time. Raise your hand if you have a family member who's ever been uninsured, and keep your hand up. Raise your hand if you have a friend, a neighbor, an acquaintance who's ever been uninsured, and keep your hand up. Look around you. We are the uninsured. Now, of course, we can't see each other, but if you do this exercise with a room full of people, you will be surprised at the reaction that at what happens. I was just invited to give a talk on single payer in Fox Chapel, which is arguably one of the richest townships in Western Pennsylvania, in a mansion of a woman surrounded by 20 of her wealthy friends. I almost didn't ask this question because I thought, ooh, nobody's going to raise their hands. There was going to be this awkward silence. But I asked the questions, and women started raising their hands. In the end, almost one half of the group raised hands. It just goes to show you that we are the uninsured. Now, this is part of the audience participation very early on. It gets them to lean in, to buy into the presentation, and likely makes those skeptics when they're forced to look around the room to recognize the human face of their healthcare system. I do this in every presentation, and from 1/3 to 100% of the people raise their hands. And sometimes they raise both hands. Now, I like to think of the U.S. healthcare system like a pie, a very messy pie. And this is how I explain the U.S. healthcare system in 5 minutes with one slide. About one half of us get our health insurance through our employers, and you can see this by the blue piece of the pie. It's employer-sponsored health insurance. About 5 to 7% of us in the orange have individual market, are in the individual market or the non-group market because our employers either do not offer it, it costs too much, or it's self-employed. About 20% or 1/5 of the population are covered under Medicaid, a large public insurance program for poor children and adults, as well as those with disabilities and long-term assisted living. And yes, Medicaid covers nursing homes for the elderly. 14% are covered by Medicare, as you can see here, and Those are for individuals over 65 and those with end-stage renal disease. 2% have public insurance, such as the VA and the Federal Employees Health Benefit Plan. And finally, 9 to 10% of us are in the green slice, are uninsured. Now, with this one slide, you have described the U.S. healthcare system. All the building blocks are here. Everything you say from here on out can refer back to this pie. Have it as a slide. You can draw it in a flip chart, or you can draw it on a napkin. Now, every state is different. And I use the Kaiser Family Foundation website, State Health Facts, to create my pie charts. For those of you who have never used this website, it is a gold mine of information, especially at the state level, to find out who qualifies for Medicaid, CHIP, the percent of uninsured in each state, the number of uninsured in your state, and lots of other facts. So for example, in that first slide where I showed the number of uninsured in Pennsylvania, or who would die in Pennsylvania, I got that from Kaiser Family Foundation. To create my pie chart of Pennsylvania, I click on, so what I do is I just go to, oops, this little box is in the way, I go to Pennsylvania, and then I click on it, and then I scroll to the healthcare fact that I am interested in. And once you have your percentages, you can make your own charts. So if you are from Pennsylvania, you can mention that more employers offer health insurance and more workers take it up, so 54%. And as a result, more people are insured under health insurance. Fewer people end up having to go on the individual market, or that orange slice, and PA happens to be a state that expanded Medicaid, so as a result, fewer people will be uninsured. Okay, so you see that this larger piece of the pie, this is a larger piece of the pie, and by definition, this piece of the pie will be smaller. Or if you are from Texas, so you go to the state, you click on it, and you open up the health facts that you want, and then you create your own chart. You can see that far fewer people get employer-sponsored health insurance, more in the non-group market, and as a consequence of not expanding Medicaid, fewer people are covered by Medicaid. And finally, that means that if this piece of the pie is smaller, this piece of the pie is smaller, this piece stays the same. I guess there aren't any elderly in Texas. This piece of the pie will, by definition, be larger. And it's simple geometry. Most people understand this. You can use this schematic to talk about the ACA, about the American Health Care Act, the AHCA, and the Better Care Reconciliation Act, all in one slide. So by creating the employer mandate, what the ACA did is it made this piece of the pie bigger. By creating the individual mandate, it made this piece of the pie bigger. By expanding Medicaid, it made this piece of the pie bigger. And by definition, it made this piece of the pie smaller. Now, the AHCA and the BCRA, herewith known as the evil twins, by eliminating the employer and the individual mandates. So by eliminating the employer mandate, by eliminating the individual mandates, by repealing Medicaid expansion and then underfunding it, by definition, are going to make this piece of the pie, or the uninsured, bigger. Now, does this make sense? I usually stop to make sure people are following me at this point. I'm not going to do it now, but I suggest that you do stop and at least say, does this make sense to you? Now, you can use this slide for one more thing, and that is to talk about costs and about each individual slice of the pie as well. First, we're going to ask, how much does employer-sponsored health insurance cost? And usually, I try to get some audience participation, and people say, they shout out numbers, right? And most people are shocked. Now, I'm including this slide because if you're giving grand rounds, you will want this kind of detail. If you're speaking for 20 minutes to a community group, you will not have the time. This slide is from the 2017 Millman Medical Index that shows that in 2017, the average cost for a PPO for a family of 4 is almost $27,000. Now, this includes what the employer pays and what the employee pays from payroll deduction as well as out-of-pocket costs, and you can see that it is $11,685. Now, what does this mean to the average American? Well, particularly that one, the average median household income that is $56,516 per year, or to the worker making $15 an hour, or the one making minimum wage. So even if the employer offers it and the worker pays his or her share, it means 21% of the gross income for the median household, 37% of the gross income for the worker making $15 an hour, or 77% for the person minimum wage. And I gave you the minimum wage for Pennsylvania. You can see at the bottom the U.S. Department of Labor. In the references, you can go ahead and put in your state and come up with a statistic for the minimum wage for your state. Now, Now, of course, as Yui Reinhardt wrote in the New York Times, no way, these are my words, no way that someone making minimum wage or even the U.S. median household income would be offered a PPO, but just the same. This was the reason, of course, the exchange and the subsidies were created. You can't possibly mandate someone to spend 37% of their income on health insurance premiums and out-of-pocket costs. Now, I want you to remember this number, $11,600 and 21 or 37% of their income. Now, one of my favorite slides from the Kaiser Family Foundation comes from their yearly survey of employer-sponsored health benefits, which looks at cumulative increases in 4 domains. And you can see at the bottom is inflation, the dark bottom line, which has increased 44% since 1999. Workers' earnings, the light blue line just above it, which has barely kept up with inflation. And then the health insurance premiums, which have increased a whopping 213% since 1999, and workers' contributions to premiums, which have increased 242% since 1999, one of the most important reasons that workers' incomes have flatlined for decades. Or, if you don't have very much time, you can use this slide, which I used at a recent Council Chambers 5-minute live presentation on single payer, which basically has the same information, right, the $27,000 per year, and then the increases in premiums and in workers' contributions. And it has all the information from the previous 2 slides, but much more concise. Now, as you move around the pie chart, you can also talk about Medicaid, and you can use this slide with a medical audience. I have found that not many physicians or trainees understand how people qualify for Medicaid, and actually, the only people that I know that know about this are those on Medicaid. So I tell them everything you need to know about Medicaid is on this slide. And remember, every state is different. First, Medicaid is based on 2 things, right? One is it's based on the federal poverty level, which for a family of 4 that you can see on your right in 2017 was $24,600 per year. And number 2, it's based on age, income, and disabilities. And I do spell it out because most people can't actually believe that this is how states determine Medicaid eligibility, symbolized by the blue bars. So if you're a child between 0 and 1 year of age, your parents can only make up to 220% of the federal poverty level and qualify for Medicaid. The day your child turns 1 to 5, your parents can only make up to 162% of the federal poverty level and qualify for Medicaid. And the day your child turns 6 to 18, your family can only make up to 138% of the federal poverty level and qualify for Medicaid. And that's the reason why in a family of 3 children, parents make this much money up here, and they have 3 kids. The baby will qualify for Medicaid, but the 3-year-old and the 10-year-old will not. Now, CHIP was created in 1997 to do what? It was created to pay for health insurance for children whose parents made too much for Medicaid, but not enough to pay for private health insurance, which, as we just saw, is very expensive. And every state is different, and in the state of Pennsylvania, it covers children whose parents make up to 319% of the poverty level from 0 through 18 years of age. Now, Medicaid also pays for pregnant women who make up to 220% of the federal poverty level, and as we know, it covers about half of all births in the United States. And for those states that have expanded Medicaid, such as Pennsylvania, it covers adults with children up to 138% of the federal poverty level, adults without children up to 138% of the federal poverty level, as well as the disabled, SSI, and for long-term assisted living for seniors who spend down their income 219% of the federal poverty level. Now, while children make up about 40% of the caseload of Medicaid, only 20% or less than 20% of the budget actually goes to children, while 80% of the budget goes to pay for all of this. So the blue bars represent eligibility after the expansion of Medicaid. Now, I will show you in yellow, 2013, before Medicaid was expanded in Pennsylvania. And this is what eligibility looked like in Pennsylvania. And you can see that it's much more restricted, particularly for adults, and adults without children were not eligible at all. And one last thing that I wanted to show you is that they're in states such as Texas that have not expanded Medicaid. I didn't show you the bars for all the other populations, but adults without any children are not eligible at all, and adults with children can only make up to 18% of the federal poverty level and qualify for Medicaid.
Mm-hmm.
And now this graph also shows pretty dramatically how expansion has increased the number of individuals on Medicaid, and how by repealing the expansion and capping it or turning it into block grants would decrease the number covered. Now, I lied. There is one more thing that you need to know about Medicaid, and this is the third thing. Medicaid is funded through the state and federal government according to a formula in which richer states, such as Massachusetts, pay more, and poorer states, such as Mississippi, pay less. This is called the Federal Medical Assistance Percentage, or FMAP for short. There's also a multiplier, which is based on the FMAP, that gives states even more money. And so it means that in a state like Mississippi, for every $100 worth of health care, the state of Mississippi only pays $25, right? They're getting $100 worth of health care for $25. It's a pretty sweet deal. Now, the AHCA changed all this and gave states 100% match for those states that expanded Medicaid for newly eligible individuals through 2016, and then phased it down to 90% by 2020, but never below that. So basically, up until 2016 and now until 2020, closer to 90%, it covered 100% of these newly eligible individuals, all of these, and then all of these here, okay? So states continue to pay the traditional Medicaid match rate for the increased participation among those currently eligible. However, this is a huge target of the AHCA and the BCRA, as we shall see. So now you can move on to the uninsured. This is a pretty well-known slide from PNHP with a sharp drop-off in uninsured following the enactment of Medicare and Medicaid that you can see there in 1965. The gradual drift up in the number of uninsured and AHCA in 2010, and the drop-off again in the number of uninsured and the projected number going forward without the possible effect of the AHCA or the BCRA. Now, there are consequences to uninsured, and I include barriers on elderly adults according to insurance status. And we can see that among the uninsured, they're much more likely to go without usual source of care, postpone and go without care due to cost, and finally go without needed prescription medication due to cost. Now, you choose your own graphic here. If you're speaking to pediatricians, you insert a graph about children going without care due to being uninsured. If your audience is an OBGYN, you can do the same thing for women and mammograms. If you're speaking at an ID conference, you can insert statistics about HIV/AIDS. If you're speaking in front of oncologists, insert slides about cancer care. You have those statistics and you can draw your own graphics. Now, next you add, so how much does this whole pie cost? And people never come up with the right answer for sure. This is from Health Affairs from last year, and in 2016 we spent, they have it in billions, but it's basically $3.3 trillion that we spent on healthcare in 2016. And to put it into perspective, we've spent $2 trillion on the wars in Iraq and Afghanistan since the beginning combined. We're going to end up spending more money because of the veterans, but it's pretty amazing how much money in comparison we spend on healthcare every single year. Now, some people like to show another PNHP slide with the amount of money we spend per capita compared to other industrialized, another great slide, and it's available to you through the PNHP slide set. The point is we are spending a lot of money. Maybe our outcomes are twice as good. Well, when compared to OECD countries, our healthcare system and outcomes fare far worse. Access
okay?
Our maternal and infant mortality higher. And again, this is from the PNHP slide set. You can choose whichever outcome you would like, but the bottom line is no, we are not getting our money's worth. Or if you'd rather skip the graphs, you can say we outspend every other country by twice as much. We spend 18% of our GDP, and yet compared to other industrialized countries, we rank number 4 in healthy life expectancy, number 25 in preventable deaths, and number 37 in the world's health system. It just depends how much time
Could the person talking in the back mute their phone so we don't have to hear them?
Thank you. So it just depends on how much time you have and if you think your audience would prefer a bar graph or over text. But the message should be clear. We're not getting our money's worth. Now it's time to talk about how we fix this, right? One of my favorite quotes from Donald Berkwick is, "Every system is perfectly designed to achieve exactly the results it gets." Now, for those of you interested in the details of the ACA, here they are. You go back to the pie and you describe the employer mandate, and you can even talk about the number of employees and the number of hours and so forth. It created an individual mandate and the health insurance exchanges, marketplace with different metal tiers that covered more or less of the healthcare costs for those who made between 100 and 400% of the federal poverty level, and then gave them premium tax credits to cover the cost of health insurance and subsidies to constrain the out-of-pocket costs. Because, as we just saw, health insurance is financially beyond the reach of many individuals, so it's only fair that the government pay health insurance companies when the individuals can't. And I'm saying that tongue-in-cheek, of course. Now, if the individuals did not purchase health insurance, they were subject to penalties. It expanded Medicaid and offered financial incentives to states to and we have seen. And finally, insured private insurance companies follow some rules. The ACA was created to cover many of the gaps that existed in our healthcare system, but as we know, it left many, many gaps still gaping. There are exceptions to every rule, especially the ACA, and here you have a list of individuals exempt from the mandate. We're not going to go through all of them, but you can see that there were a lot. In fact, according to DHS, about 24 million individuals are exempt from the mandate. Now, say that you did not suffer a flood or from domestic violence, were not bankrupted by medical bills last year, or had a utility shutoff notice, and you make just over 200% of the federal poverty level, you work for a company that has fewer than 50 employees, so you're on your own. Now, according to the ACA, you will not have to pay more than about 6.3% of your income on, well, premiums. Let's just say, let's see what this means for you and your family of 4. So this is from Kaiser. It would be great if people could mute their phones until we get to the question period, which is going to be in about 15 minutes or so. So you go to this Kaiser Family Foundation subsidy calculator, and you plug in all these things that they ask you. So you put in Pennsylvania, your zip code. You say that you make $50,000, which is similar to the median household income. Your spouse does not offer health insurance. There are 4 people in your family. One of you is 35, the other is 38. You have 2 children, and nobody smokes. And you hit submit. You are told that you are likely eligible for financial help. In many states, depending on the age of your children will likely qualify for Medicaid, or at least for CHIP, although in Texas, the limit is 206% of the federal poverty level. So your income at 205% of the federal poverty level, you just squeeze by, and God forbid that you get a 10% per hour raise, then you'd be out of luck. But just say you're not in Texas and you have 19-year-old twins who live at home, you are still out of luck. Now, your silver plan with an actuarial silver plan value of 73% doesn't cover all your costs. And in fact, if you actually need health care, you can spend another $11,400 in out-of-pocket costs. That is the maximum. In-network does not include out-of-network costs, which means that your premium and out-of-pocket costs, you can spend almost $15,000 in 1 year, or practically 30% of your income on health costs in 1 year. And so you remember that the maximum, well, not the maximum, but the out-of-pocket cost for that PPO for a family of 4 was $11,600. This is actually more. You can see why people are so pissed off about Obamacare. It doesn't really matter if the insurance company raises its costs, because people on the exchanges will still get their premium tax credits. I mean, the government still pays, so our tax money is going towards that, but they will still get their premium tax credits. But nothing protects them from these annual costs if they happen to get sick, or if they're so sick that they can't work and pay for health insurance. They can lose their house, they can go bankrupt, and as you know, that about 60% of all personal bankruptcies are due to medical bills. They can then qualify for Medicaid, which I guess is a silver lining. So 32 states, including DC, and symbolized here in orange, expanded Medicaid, and 19 states, symbolized in gray, did not adopt Medicaid or expand Medicaid. And had all the states expanded Medicaid, we would have had another, we would have covered another 5 million Americans. Now, we must give credit where credit is due, and the ACA, for all its flaws, did accomplish some things, including all the things here. Covered 11 million adults through Medicaid expansion, insured 9.4 million through the exchanges, paid 32.8 billion in advanced premium tax credits directly to insurance companies, prohibited coverage denials due to pre-existing conditions, eliminated lifetime and annual limits, required coverage of dependent children until the age of 26, prohibited rescission, expanded community health for primary care providers to practice in needy communities, covered HIV screening without additional costs, and things. Now, the other thing that I think it did is it gave us a new normal. At least everyone now agrees that children should remain on their parents' health insurance until they are 26. Even the evil twins agree on this. I don't know if I'm being very harsh on the twins, I think. But now a brief look into the future. I never know how much time to spend on the American Health Care Act or the Better Care Reconciliation Act. I keep hoping they will go away like boils, but as of tonight, they're still among us, so we should talk about them. Now, there are differences between the AHCA and the BCRA. Wording might differ, and so do the cast of characters, but the end result is the same, which is horrifying. Now, I've taken the major principles of the ACA and compared them with the principles, such as they are, of the two options in Congress right now. It's important to point out that many of these stipulations do not take effect until after the midterm elections or until the next presidential election. Now, without spending too much time on this, just very briefly, the employer mandate would be repealed, as would be the individual mandate. There obviously should be no penalty if there is no mandate, but the evil twins have managed to find one, the proceeds of which would go directly to the insurance companies. Instead of income-based premium tax credits, all credits would be age-based, with older individuals paying up to 5 times more than younger individuals. Insurance protections such as the actuarial value, essential health benefits, pre-existing conditions, and even lifetime and annual limit prohibitions would become state options. Medicaid expansion would be repealed, as would be the new FMAP subsidies that we just learned about to the states. Medicaid funding would be converted to a per capita allotment and give the option to the states to receive a block grant for non-expansion adults and children, or maybe just non-expansion adults, and require them all to work, although maybe not require the children to work. And never use public funds for abortion, which is already law, and prohibit Medicaid funding for Planned Parenthood for 1 year. Now, it will rely on tried and true health savings accounts and high-risk pools to pay for healthcare costs that we know don't work. And the only thing that they seem to agree on is that dependent coverage up to 26 should be retained. The bottom line is that it will result in 22 to 23 more uninsured in 2026, which is going to be about 50 million. When you add on the already expected to be uninsured, about 50 million. So we know the bills in Congress would be a huge transfer of wealth from the poor to the wealthy, with the top 1% seeing their entire income increase by 2% if this becomes law. This is from the Urban Institute Tax Policy Center. It's very interesting, and this is a graph that I made from their statistics. So we've given the Democrats airtime and the Republicans as well. Now it's time for the people. At every presentation, I ask, if you had $3.3 trillion to design a healthcare system worth $3.3 trillion, what would it include? And I ask people to come up with 5 or 6 non-negotiable guiding principles. So I want everybody to do a little bit of audience participation. If you can use your chat little option, or if you want to say it out loud, we will keep a list. But I would like people to participate right now and give me a few guiding principles for a healthcare system worth $3.3 trillion. Okay, coverage for all, universal. Okay, everybody's saying universal. Give me another one. Healthcare for all. Okay. No limits, no copay.
All necessary care.
Low
All necessary,
deductible.
so comprehensive.
Low
Not for
deductible.
profit. Affordable, okay.
Low deductible.
So no deductible, so we're going to make that affordable. Evidence-based medicine, I see that. Everyone pays in. I'm giving you the money. You do not need to come up with the money. No wasting money. High quality, okay. Safety, transparent, which would be like accountable, I think. Accountability, somebody just said it. Not for profit, no profits. Treat like a utility, no copay. Focus on prevention, so that's going to be evidence-based. Negotiate drug prices. I'm giving you the
affordable medication.
Affordable medication. Okay. Prevention, which is going to be part of evidence-based. No pharma advertising. Equal. Oh, okay. Equal or just. Okay. Prevention, part of evidence-based. I think 100% coverage, so comprehensive. Simple funding payment system. Okay, I'm giving you the money. You don't need to worry about that. So 1, 2, 3, 4, 5, 6. All right, guys, automatic registration. All right, very good. I think we're going to stop because we are coming up with the same. I think somebody just said dental, nursing, everything. So that would be comprehensive. Great. Now what you're going to see is not magic, or it is a little bit magical, but this is a healthcare system worth $3.3 trillion. I did not just make up the slide, okay? People said universal, comprehensive, affordable, evidence-based prevention, accountable, equal, or just. And this is the list that I have come up with. Universal, affordable, accountable, accessible, comprehensive, high quality, evidence-based, equitable. So I hope that you're all amazed that you have come up with the exact same guiding principles. I have given this talk over 100 times. And over 100 times, I always ask this question. Everyone agrees on the same guiding principles. We all agree on what we want. Now we have to agree on how to get there. I encourage you to do this little audience participation exercise with your audience, and I guarantee you can call me back if it doesn't work. I'm going to give you my email at the end. Email me if it doesn't work. But as I said, 100% of the time, everybody comes up with the exact same guiding principles. And what you can do is you can have a list prepared ahead of time, and you can ask people to call it out, or you can write it down, or people can remember it. And then afterwards, after people have given you their guiding principles, you ask somebody to read your list, and it will be the exact same list. And here, my friends, is how we get there. House Resolution 676 in the U.S. Congress, co-sponsored by 113 representatives. It is a single-payer bill. And what does single-payer mean? It's a financing system where everybody pays into one pot, and the one pot pays the provider. It is publicly funded, privately delivered health care. It is improved and expanded, or expanded and improved Medicare for all. It is portable. There are no cost sharing. That means no copays, no deductibles, co-insurance, or premiums. You have free choice of providers, and the providers can be public, not-for-profit, private entities, and HMOs. What is not allowed are investor-owned, for-profit entities or health insurance that duplicate services. It is for all individuals residing in the United States and covers. And here is the list. And then you read the entire list, the whole list, to your audience. Now, most people will want to know, first thing they want to know, okay, this is great. How are we going to pay for this, right? Now, HR 676 gives general principles for funding. Honestly, they don't say a whole lot other than we're going to have a modest tax on the top 5% earners and some tax on unearned income. So specific numbers can be found in an unofficial analysis published by Gerald Friedman in 2013, and the reference is here for you, and it is used by Representative Conyers' office as their guidance for financing. And you can see that it will use existing sources of federal revenues for healthcare, very small tax on stock trades and other unearned income. there will be a 6% high income surtax for households with incomes above $225,000. Under income also gets a 6% tax, and then there's going to be a 6% payroll tax paid by employers on the top 60% of income earners, and a 3% payroll tax paid by employers on the bottom 40% of earners. So the good news is that according to this analysis, 95% of Americans would be better off with a single payer system. So essentially the bottom 95% income earners would see an increase in their after-tax income, and the top 5% would see a decline in their after-tax income. So the way that I like to look at it is this bar right here are the richest 400 Americans in the United States. They make over $166 million a year. They would see a 30% pay cut and still make $116 million a year. Now, if we go back to our guiding principles, you see that single payer meets every single criteria: universal, affordable, accountable, accessible, comprehensive, high quality, evidence-based, after the establishment of the National Center of Universal Quality and Access, and finally, equitable. Now, who supports this? Well, who wouldn't? Aaron Carroll's survey of physicians from an AMA database in 2002 and again in 2007 demonstrates that the majority of physicians support government legislation that would establish a national health insurance program. And if you're giving this to a group of physicians that you know are pediatricians or emergency medicine, then you just go ahead and highlight that bar for them. Now, most Americans support this as well. And I have a couple of polls for you. This one is a Gallup poll from May 2016 at the height of the election campaign. Individuals were asked if they would favor replacing the ACA with a federally funded healthcare program providing insurance for all Americans. And you can see that 58% of all adults support that they were in favor of that. 73% of the Democrats were in favor, and even 41% of Republicans favor, if we were to repeal the ACA or replace it, they would favor federally funded health care for all Americans. And even among those that are fervent repealers of the ACA, 53% supported a federally funded program. So this is a very, very recent poll in April of 2017 from the Economist YouGov, and the reference is there for you. And here you see that of all Americans, the percentages keep going up, particularly after the AHCA and the BCRA. 60% of Americans, 75% of Democrats, 58% of independents, 46% of Republicans, and even 40% of Trump voters are in favor of expanding Medicare to provide health insurance to every American. So we agree on what we want our healthcare system to look like, our guiding principles. We agree it should be federally funded healthcare system for all. We certainly have the money. Now we have to empower our audience to do something about it. So the last two slides are how do you talk to your audience to commit them to do one thing? And of course, it depends on your audience. For a medical audience, it could be just to learn more about the healthcare system or about single payer. So have a reading list available, direct them to the P&H website or Don McCann's quote of the day, which I cannot promote enough. Maybe they'd be willing to wear a button that says, ask me about Medicare for all. That was a recommendation, a suggestion from an internist in our group. Or if they're motivated, write a letter to the editor or an op-ed, or maybe a group of physicians want to get together and meet with a local editorial board. If you do that, make sure that you go there with a specific ask in mind, such as get the editorial board to write an editorial in favor of single payer, or for them to publish your op-ed. Alternatively, the group might be willing to co-author a letter to a professional organization. We just finished doing that to the academic pediatric societies as well as the AAP in support of single payer, which was co-signed by 157 pediatricians from the PNHP web database. And I'm sure Matt would be very happy to help you do something like that. Perhaps they will be willing to give grand rounds or to invite you to give grand rounds elsewhere. If there is a local single-payer community organization, ask them to join. And if there isn't, ask them to create one. Bring in residents and medical students. There is nothing stronger than a physician's voice in the community. For the most part, people trust doctors. Now, for the non-medical audience, simply ask them, what will you commit to do? Make a list, and don't let them off easily. For example, if someone says, oh, my congressman just won't listen, ask, how can you get him to listen? And keep pushing until they come up with an answer that fits and that they're willing to commit to do. Now, many people will still want more information, so direct them to PNHP, Healthcare Now, or their local single-payer organization websites. Also, HR 676 is only 30 pages long. Anyone can read it. Ask them to write to their representative to co-sponsor HR 676 if they haven't already done so. Now, if their representative is already a co-sponsor, ask them to put it on his or her website. Of the 113 co-sponsors, only 8 have HR 676 as part of their website and only 2 in their campaign website. Single payer needs to be the campaign issue that they run on, and we must push our representatives to do this, especially the ones that have already co-sponsored. Ask your audience to write a letter to the editor in their local newspaper. People still read the local news. Volunteer to speak at their events and have someone commit to invite you. See if someone is willing to call into a radio show when they're discussing healthcare. Have someone commit to talking to their own physician about single payer, so to turn things around. And finally, have people commit to talking to their friends. I think is the most effective thing that people can actually do. They can lead off the discussion with, how is the healthcare system working for you? What would it mean to you to have Medicare for all, to your family? It would have saved Devontae Johnson's life.